me start to look at cancer and the key messages that we're putting on. I think our aspiration then in cancer services is England should achieve cancer outcomes comparable with the best in the world. I mean, I'd like it to be the best in the world, but comparable with the best in the world would be fantastic. But sadly, we're not there yet. And I think it still remains an aspiration, and it's something we're trying to achieve. So our overarching key messages to commissioners is about saving lives, about improving the quality of the patient experience, and about value for money. I think we've got to become much more focused on value for money and making sure what we do offer is as good as we can do, but accepting there is a limited amount of cash that we've got to do it with. We know that cancer patients in England are dying unnecessarily. We know that other countries are doing better. And in fact, if we were as good as the rest of Europe, we could save 10,000 lives. And that's quite shocking. And sometimes when I think about that, and we've been told this, and it's a target for us in the National Cancer Action Team and NCIN, and I'm sure for networks you're very aware of that. But it's actually real. And for me, last year it touched my family, and I think, gosh, it hit me really hard. And to think 10,000 lives. But the government's been easy on us and said that we should just go for saving 5,000 lives and being equivalent to the average in Europe. And we do have a spend of 6 billion each year, and that's an amazing amount of money. And it's, you know, people can argue we may not have as much money as some people in some areas, but I think it is a large amount of money, and it's important that we use it as effectively and as efficiently as we can. There are a number of myths, and when I first saw these, I thought, wow, I didn't know all of the answers, but I was surprised to see them. Cancer has more than its fair share of growth in NHS funding in recent years. Well, cancer accounts for 6% of the NHS budget, and I think the general public would be shocked with that. They would probably think that it has a higher proportion. And when I go out in peer review, this is a common sort of thing, that too much attention is given to cancer, and we should put our efforts on other conditions. But survival rates following a diagnosis of cancer in England are poor, and we could save more lives, and I think we shouldn't be too apologetic to say that we want the focus to be on cancer and saving those lives. Cancer is a secondary and tertiary issue, and I think I've been guilty of this in the past because my focus has been there and has little to do with primary care. So primary care has a major role to play, particularly in early diagnosis, and I think we've all got to focus our minds there because if we can improve early diagnosis, we can save lives. All cancer interventions are highly expensive, and we tend to hear about this in the press, but many interventions with the greatest impact are cost effective. And I think, smoking cessation, screening, early diagnosis are the things that we really can and should focus on and will save us money in the long run. Although we have to accept it is true that some chemotherapy is more expensive. And then the fifth one, interventions for cancer only prolong life by a few months. And I think some people in the press do think that about some of the very expensive drugs, and the public in there seem to think, oh, well, we're just saving a few months of life at the end of the journey. But actually what we do know is if we get the diagnosis right and early, then we can save life or give people long lives and prevent early deaths. So I think it really is important we get it right. And I think it's important that we understand that many of those myths are incorrect and make people aware of that. So, key recommendations for disinvestment. And when I looked at this slide of Stephen's, I thought, oh gosh, that's an unusual title. We don't often say disinvestment, but actually I think it's right that we do. We are trying to save money in the NHS. So, we need to reduce the number of emergency admissions and be much more proactive. Because we know late admission, emergency admission, means that the chances of survival and the quality of life will be much poorer at those stages, and use more ambulatory services and symptom control. Reducing length of stay should always be a focus. Patients don't like staying in, but also it costs us. So that's another area where we can focus our efforts, and enhanced recovery programs are proven to work, and it's important that we share that best practice because it's better for everybody. It really is a win-win. And then reduce follow-up through promotion of self-managed care. And I think we sometimes forget that patients are capable, or many patients are capable, of managing their own care and should be encouraged to do so. Investment in early diagnosis. Sometimes people get a little bit of fatigue of early awareness campaigns and cessation of smoking. Certainly my sister does. But I'm nearly there with her. I'm nearly at the end of the journey. But I think it has to be not only a national battle, it has to be a personal battle. So public awareness campaigns, and you'll have seen that. I got quite nervous. It's quite interesting, even working in cancer, that the lung cancer cough campaign that's been on TV after my 3rd week of what I thought was a cold, I started to reflect and think, luckily it went. Improved access to flexible sigmoidoscopy for bowel symptoms, and chest x-rays. And these are things that diagnostics are so important, and we need to push diagnostics as hard as we can to get early indicators and early diagnosis. And then increasing day case surgery. These are things that are not only good for patients, but they're good for survival. So we need to focus our minds on them. This slide always fills me with fear, and I think most of us, it's easy to be nervous about the new environment that we're in, but we mustn't let it distract us. And I know there's a significant number of changes for cancer networks, for NCIN, NCAT, all of us, and I think everybody in the NHS. But it's important that we maintain progress and maintain focus, because if we don't do that, we won't save lives, and we'll see that lack of saving lives in our agenda. And I think somebody once taught me, when you're going through change, see it as an opportunity. But most important, just keep your head down and focus. Let the politics do the politics, and keep focusing doing the day job, and it'll be all right. Financial challenge. You can't deny it. It's a difficult situation, and every day we're talking on the news about financial challenge. We need to make what we do as efficient as possible, and saving 20 billion is not an easy task. But we do need to make sure we reinvest it in the appropriate areas, which will overall save us money. And I think it's easy to forget that, and we get frustrated and we think about our own piece of pie, if you like, and our own concerns. But in December 2010, the NAO report said that we don't even know where we're spending our money, and we need to work that out, because if we don't know, if we can't measure where we're spending money, how do we know when we're saving? So there needs to be better information on cost of services, identified areas of investment, and identified areas of disinvestment. So we need to map and find out, radiotherapy, chemotherapy, where where we are spending the money and how we can improve it. The power of information, so this is, excuse me, this is last week's information strategy that was published, and we're giving priority to measuring outcomes, measuring processes linked to outcomes, and making information widely available. Now, information's always been there, but we've never used it properly. We've never fed it back to the people who deliver the information. And I think we've got to focus on that and ask people questions about their own data and their own information. Cancer registry modernisation should help. So we will have in England one system, moving to the NCAT system. This will improve the timeliness. And when I'm talking to clinicians, they'll always quote to you that the data's last year or 2 years away. And I think, well, we should still be looking for steady progress, and often it's used as an excuse that data's old, but we should be using them as indicators. And then Mike Richards' favourite in terms of staging, and if you catch Mike on the wrong day, I guess, he would say, if you're not staging, don't pay. Don't pay if we're not staging. And I think it really is true that if we've not got the data, how on earth can we establish whether we're doing well or not? And I know for cancer peer review it's been a frustration in terms of people have said let's move to outcomes, but we don't have outcomes data to focus to that. And I'm looking forward to a move towards outcomes data. So Di's having a day out today, but she's generally been working, that's Di Riley, they're working hard in improving data collection and cancer outcomes and service data sets and agreeing minimum data sets. And I think that's really key that we start to align our data sets so that we're all collecting the same thing so we can benchmark. New analysis is being worked through, and NCIN are producing a plethora of documents that help us understand this. And the NCIN website does give you some real excellent benchmarked information that we need to stop and reflect, not just keep doing the same things, but stop and reflect. Improved outputs. Andy McMeekin's going to run through service profiles in the later session. And I think for me, service profiles, and we've only got breast and colorectal at the moment, but these are the way forward. We can see how individual clinical teams are performing and who is achieving and who's not and how we can help them. So they're real key. So the 5 domains, you can't talk to anybody without mentioning the 5 domains. So if we run through what we're doing for each domain and saying how we can provide information, what we know. So saving lives, we do know the incidence is rising, so 260,000 and we're expecting that to rise to 300,000 in 2030. Cancer services and outcomes have improved. That's the good news, so we're getting better. But we've still got to do better still. And much of that improvement has been in the hospital sector. And I think we really do need now to focus on primary care and early diagnosis. And as I've said earlier, survival for many cancers remains poor. And if you're brought up in Rotherham, where I'm in my family, then, and I remember a patient that I worked with 8 years ago and said, what are we doing differently about lung cancer now? And I sometimes stop and think, we're not. What are we doing about those cancers? And so we should be able to save 5,000 lives if we can focus our minds to matching Europe average. And I'd like to think that we can do better than 5,000 lives and that we could get up to 10,000 lives. I don't know about you lot, but I've never previously aspired to be average. I think that's a sad case that we're aspiring to be average. And we know that late diagnosis is a serious factor. And therefore, we all have to up the ante on that. As a cancer community and as commissioners, we need to push on early diagnosis. Often you look at statistics and you think, oh gosh, here we go, we're entering anorak territory. But I think these four are really, really good graphs, really. And what we can see is there's lots of positive news that we are getting better. And, you know, we can see that for breast and ovarian, we are closing the gap. But again, if you look at colorectal cancer and lung cancer, although we're getting better, we're getting further behind the rest of Europe. So we have to keep pushing and we have to keep trying to raise that gap. The theme's going to carry on here, but sat in the southwest, you can look pretty across England, but the blue line is the international best practice, or mean. And what we can see then, and this is breast cancer, that just 7 of the PCTs have got a survival in international best practice. And if you look at London, and this is the thing that worries me, is if you look at the range, so the long tail of London of performance, how can we have such significant variation across our PCTs that we should be able to bring people closer together and move through that? Obviously, the Southwest doing better than others, but still not as good as we could do. And again, for lung cancer, and again, this is close to my heart, but for lung cancer, we can see just 1 PCT in London this time who's above the line. And we're not doing as well as we should. And then finally, for colorectal cancer, again, the West Midlands have managed to get 1 above the line. But if 1 can, surely we all can. And it's looking and sharing what are they doing. And again, in London, looking at that variation in the range really is a concern as we go through. So saving lives, it's not about just the last few months or extending the last few months. I think it really is that if we can get to people early, people can have a long life, that cancer doesn't have to be the end. And we really need to focus on that. We need to promote early diagnosis, and we need to particularly look at emergency presentation. Emergency presentation is our failure, and that we should be working together to prevent that. And it's high cost. The elderly often present late, and the elderly who we often treat by age rather than their physical state of health. And then ensuring staging is provided helps us to move to know why some services are doing better than others. So reducing mortality, improving survival. Hopefully everybody's heard of NADI. I'm just checking if, I get some people who say, not sure. National Awareness and Early Diagnosis Initiative. So awareness campaigns, GP diagnostic support, so the risk assessment tools to help GPs decide on referrals, improvement of access to diagnostics. It shouldn't be that GPs are creating a barrier to the service. We should be looking for GPs to get access quickly to our diagnostics. Endoscopy. The classic statement here that Mike Richards always tells us, that we've got greater capacity in endoscopy in Poland than we do have in England, which makes you realise we perhaps aspire to be better than Poland, but we're not. And then focus on improving or reducing the emergency presentation. Reducing mortality again. So you should have seen, I certainly did, the National Lung Campaign, and you should have seen the 3-week cough. We're waiting for Cabinet approval, but subject to that, we should be having a national bowel screening campaign in September. There's national work to support primary care and the Wills diagnostic areas, and then campaigns in January to March for blood in urine, breast cancer in over 70s, and trials on trying to use outside TV. There's an assumption that you can touch everybody with TV, but there are other means, and looking at different ways of promoting early diagnosis. What's quite interesting, I always find, is that the timing of these events are such that we're not allowed to run them through the Olympics, which I always think, gosh, the Olympics is more important than saving lives now, that we've got to fit the timing around so that we don't upset anybody during that period. Other initiatives then, proposed local activities, GP leadership and engagement, and I'm sure there's many people from the networks here that support for regional campaigns and additional funding for that. New site bids for ovarian, constellation of symptoms, increased stretch in national and regional campaigns, and new awareness raising programs. So there's lots going on, and what we've got to do is try and make sure everybody's aware of everything as we go through. Improving life then, we want to see improvements in outcomes, and it's relevant for those people who are surviving cancer. I think that's an area that we often forget, that we go through our primary treatment and then we forget that the battle still remains. So reducing illnesses associated with cancer treatment, so side effects of radiotherapy, reducing the recurrence of cancer, and then some of our Cinderella areas, which is the sort of physical and psychological support that people need when they've suffered from cancer, and getting back to normality. And I know we all wake up on a Monday morning and say that we don't want to go to work, but actually it's a significant part of your life, and if you've suffered with cancer, it's an important part to get back to work and be able to sort of take part in the normal way of life. So there's a range of initiatives as well, and partnerships with NHS Improvement and Macmillan. I'm not going to read all of those, but there's lots of them going on, and you can see there as you look through that and look through the slides, you'll see those. Enhancing recovery, and I guess it's enhancing recovery, getting better faster, but it's not just about that. It's about appropriate treatments delivered with clinicians with the right skills and the right experience for high quality care, and that should be across England. It shouldn't just be at centres where we've got additional skills or laparoscopic skills. We want everybody to benefit from that, and it really is a win-win for everybody in terms of if we can use the new techniques, then we can reduce the length of stay, we can get people back to work faster. So, and sharing that best practice beyond cancer. So enhanced recovery programs works for knees and hips as well as gynae cancer. Okay, increased day overnight breast surgery, and again reducing admissions. We can do it. It's just thinking at the early end about symptom control and making sure that people know what they're doing. Most of you in the room will have seen this slide. You won't be able to see it here, but you'll know what it is, I hope. And it's the Patient Experience Survey from 2010. And it was probably the biggest survey of its kind, 67,000 patients involved, and it gave us a real picture of how we're doing from the patient perspective. We're expecting the results of the second survey in the summer, and I'm told the summer's July. I bet it moves to August, but they are doing that analysis as we speak. And we should then get some comparison about, can we make these improvements? And it's interesting that when I've gone round on peer review and talked to people about their patient experience, they've said, oh, well, the National Patient Experience Survey doesn't really tell us the real picture. They want us to use their local one. And I think, well, that's fine, as long as each year you're getting better and better. But I'd hope that people have prepared to try and make things better for patients, and they've got access to information prescriptions, communication skills training. We've still got a number of clinicians who don't think it's important, and I think it's really important for them to see the data about how patients feel. The MDT Fit programme, about more effective patient MDT working, and then the important role of the CNS and the key worker, and I think most of us are aware of that. So the target here is really turning those reds to greens as fast as we can in terms of how patients move forward. I'm nearly there, bear with me. Okay, so the final domain is about improving safety for patients. So measuring the 30-day mortality after surgery is another key area. Ensuring safety in chemotherapy, elective chemotherapy in the NCAT report. And acute oncology services is certainly new for peer review and new for many people. And I think that's a major change and a major step about looking at trying to keep people out of emergency admissions. Peer review, love it or hate it. I know we're like the Marmite of the Cancer Action team, but what it does do is it gives us a real measure of where we are and how we are performing, and whether we're getting what we pay for. And we know in this challenging climate that keeping specialist nurses in teams is going to be difficult. So to sum up then, what can commissioners do now? How can we make this better? So I guess the key point is investment in early diagnosis. Ensure that we've got staging detail. And remember, no staging, no payment would be a real indicator. Monitoring the number of new cancer patients presenting as emergencies, so that should be reduced. And then reducing emergency admissions is a great way to save money and save lives. Seek advice from those with the experience in commissioning cancer, both nationally and locally. And I know many of the networks are here today, but working with the networks is key to understanding where we are. And in summary then, we're making steady progress, but we've got a long way to go, and we still have to maintain our focus in challenging times if we are going to save 5,000 lives. Okay, that's what you've got to do. I feel like saying, dismissed, off you go, do it. But I'm not. I've got Jane, who's going to come up next, and Jane's going to tell you a little bit about commissioning services as we go through.